Okay, so we are moving on to outcome or impact evaluation. And again, this is in preparation for, too many papers up here. In preparation for your exercise. I don't know if you had a chance to kind of read ahead about what the assignment is for outcome evaluation. But you're going to be designing an outcome evaluation, and so let's kind of I'm going to give you just a few, this is probably the thing that people are most familiar with, I imagine, right? Outcome evaluation, it's what we tend to think about when we hear about the word evaluation. As a reminder, one of the steps in doing evaluations is focusing your evaluation. After you've engaged your stakeholders, after you've kind of mapped out your project, after you've figured out what your primary stakeholders are really going to prioritize, what they value, what information they need in order to either make decisions about the program, decide whether it can continue, improve it, et cetera. So your outcome evaluation design and your process evaluation design will definitely reflect these three priorities here. Obviously the resources that you have for evaluation, we know that there's never enough resources available for evaluation. There's some estimates that suggest that up to 25% of, you should have about 25% of program costs available to do a really good evaluation. That's rarely the case. Usually it's 5% or less. So resources is something to consider. Also, the priorities of your primary stakeholders. What are they going to care about? You definitely want to make sure that your outcome evaluation is used, and if you're not targeting the priorities of your main stakeholders, whatever you end up presenting, no matter how well designed, may not be of use to anybody. And then finally, taking into consideration your logic model, your theories of change, components of the program, gaps that you may want to fill in knowledge. All of these together help you think about the focus of your evaluation and then your evaluation design. So, this is a vast topic, choosing a design for your outcome and evaluation, outcome impact evaluation. Huge. We could probably spend the whole week on this, but good thing we're not going to. But I just want to highlight a couple of issues for you and then maybe share the story that, about what we did in our Healthy Start project. So definitely you want to think about causality. Ideally, you want to be able to say that your program led to certain outcomes. And in order for causality to happen, you don't have to have a randomized clinical trial. You do have to meet these criteria, though. The program has to precede the observed outcomes. The program theory has to predict the outcomes that you're choosing for your evaluation. And then the presence or the absence of the program has to be correlated with the observed outcomes of interest. And there shouldn't be, or one of your goals with your evaluation is to rule out plausible rival explanations. So when you think about your comparison group, when you think about what you're doing, you want to design it so that ideally you can rule out all alternative explanations to why you're observing what you observe. Again, this takes money, it takes resources. When we think about, but often we think about, only the randomized trial can tell us whether something is causally related. And that's not the case. Only about 15% of published evaluations are actually randomized trials. I'm not knocking them, but they're hard to do. They're resource intensive. You can't always randomize people to get services or not. Quasi-experimental are another 32%, and then non-experimental designs are the 48%. So it's important for us to think about validity of our designs. There's internal validity, which assesses the extent to which we can confidently attribute the cause of the observations in our outcome evaluation to the program. So within the program, we're thinking about internal validity here. And then there's external validity, which assesses the degree of confidence that we have in generalizing our findings to populations or setting that are similar to the ones that we're studying. So outside the program, there's external validity that we want to think about too. Our designs differentially affect internal and external validity, so we have to pay attention to those. So again, for internal validity, can we establish that there was a cause and effect relationship between the key independent and dependent variables? Here we have construct validity. This is how well we operationalize our variables to represent what it is that we're trying to measure. We've been doing some of that when we've been thinking about our indicators, but we haven't paid a lot of attention to their construct. And then also external validity is, can the findings and conclusions from the evaluation be generalized to other times and places? So many of you said that you were doing evaluations or going to be doing an evaluation. How many are thinking mostly about the internal validity? Anyone thinking about the external validity of your evaluation design? Fewer. And then how many are thinking about both? Are you thinking about validity at all? Okay, so hopefully you will be thinking about validity. Now, so for your study design, you certainly want optimal designs to promote causal inferences and to minimize threats to internal, construct, and external validity. So, of course, the experimental design is ideal because it takes care of a lot, not all problems. Quasi-experimental designs have comparison groups, but they're not selected randomly. I gave you a document in your notebooks, in your binders, that talk about, we're not going to go over these because it's too much, we don't have enough time, but Cook and Campbell definitely talk about different threats to validity. Have you heard about threats to validity? Threats to validity are, in fact, that. They pose a threat to your being able to confidently say, yes, my program caused that outcome. For example, with the issue of history, history is when something happens and it impacts the population as a whole. So for example, I did a lot of work in the HIV field for many years, and when Magic Johnson came out with his disclosure that he was HIV positive, everyone started paying attention to HIV and that issue. So all HIV interventions at that time were impacted by that historical event. Anyway, the document that I gave you is a short summary of what all of these are. I'm also sharing this slide here because this gives you an idea about a couple of things. One is there is no ideal design that takes care of all of these issues. And what you're doing when you select your design is you're prioritizing some threats to validity over others. So if one of them is very important to you, so for example, in your follow-up, if you're worried about statistical regression, then you would probably try and choose either a before or after design or a case study design. Again, if you're concerned with maturation, you might choose one of these. And this is not the universe of study designs. This is just an example of study designs that minimize certain threats to validity. Okay. So these are things that you really want to consider. Again, think about your stakeholders, who your primary stakeholders are, what matters most to them, and then you can think about your study design for your outcome evaluation. Before I go into an example, I just want to know, does anyone have any questions so far? Yes?
You know, we're talking about all these study designs and things of that nature, and it got me thinking it's kind of a different track, but for a public health authority, because my son is a public health authority, at what point do you go and seek institutional review board approval and consider it research outside of public health practice? Because this is sounding very research-oriented.
Good question. Does anyone, I have an answer to that, but others may have experience or want to answer that. Yes?
I have an internal IRB with the Department of Health. Sorry. We have an internal IRB at VDH, and I think, I'm not on the program eval staff that's in the Office of Family Health Services, I'm in the EPI unit, but I believe that when the program eval staff actually do this sort of thing, they actually go through the IRB. So
you're fortunate that you have that.
yeah.
Okay.
So because I know they've put evaluation plans through the IRB.
Okay.
But that doesn't answer the when and in what circumstances.
It doesn't, because you can do customer satisfaction surveys that can also be used as a type of program evaluation, and that's fine. You don't need institutional review board approval. So I guess what I'm looking for, is there anybody that sits on an IRB in the room?
So I can tell, I've sat on a couple of IRBs, and I can tell you that they're different. I mean, each IRB has its own unique culture and what they emphasize as well. I sat on an IRB that said, anytime anything is program-specific evaluation, you don't have to go through the IRB, even though some of us argued that, in fact, it's research and we want to get it published, and for that reason we should be going. But the chair at that time felt no program evaluation is generalizable according to what he was thinking, and therefore will not accept any program evaluations. I'm just letting you know that the culture of that IRB was very much determined by that chair. And then I'm sitting on another IRB, or I did recently sit on another IRB where they err on the other side. They want everything to go through, and they'll tell you whether you're just doing program evaluation to inform just that program or those program planners, et cetera, et cetera. So I think it varies. That still doesn't answer your question. I do think you have to think about customer satisfaction surveys. I assume you're not going to publish them, and you're just going to say, oh, they're satisfied and you're doing program improvement. I think those probably don't need to go through the IRB. They're nothing but improving programs, not really research. But then there's some that are going to be gray areas, and then some people want to be safe rather than sorry. If you're a research academic evaluator, you're probably going to want to think about publishing at some point or another, so you may want to be on the safe side and go through the IRB and get approval. The other thing to think about is sometimes if you have a challenging situation, so we do research on prison populations or on homeless, you may want to go through the IRB anyway, because they may have a unique perspective to help make sure that you're not in any way harming the population that you're going through. So those are very different reasons to go through the IRB, but anyway, I'm just sharing my experiences. Did I see some? Okay, there.
Yeah, I work in Arizona also, and I can tell you at the health department, at least in my bureau, we've submitted a few IRBs just simply to get exemption because it's public health practice. And we still do a lot of the extra paperwork and everything, but we've done it either because we thought we were hopefully going to publish things that might be deemed controversial. In the state of Arizona, there's controversy over teen pregnancy prevention, how you educate the teens. And even though they were federally approved questions, we still went through IRB and had an assistant director review things and everything like that too. So there would be no public backlash, I think, is probably the reasoning. We have another program where we go into bars and we train the staff to help try to identify sexual aggression to prevent sexual violence before it escalates. And because we're working so closely in the public and that's starting to spread, we and all the bars are kind of hearing about it, we also sought exemption for that too, because we want to further evaluate more past like paperwork evaluation. But it's just because of the connection, and again, the controversial issue of sexual violence, that we wanted to cover our bases so no one could come back and say, you shouldn't be doing this, or you should not have been doing this for as long as you have been. So we do it as a cautionary thing with anything that could be deemed controversial, especially from like a public perspective.
Did that answer your question?
Yeah, a little bit more so.
Okay.
Your response to, thank you.
It's gray. It's gray area. There's no black and white here. Okay, any other questions about design? I'm going to tell you, give you an example of what we did. So I mentioned to you that we did this Healthy Start evaluation many, many years ago, and we had a geographically defined catchment area. They were called target areas, and we targeted the highest risk areas of the city. We did a socio-demographic reproductive profile of all the census tracts in the city, and identified those that were highest risk, and those were our target areas. We identified Okay, so the challenge was, so we actually identified the highest risk areas for our target areas, and then our challenge was, okay, so what do we use as a control situation? So again, this is the conceptual model of Healthy Start, and I won't go into that very much. I mean, I think you're kind of familiar with what the basic idea is of Healthy Start. This is the map that was generated around that time, and the very dark brown areas of the city, this isn't everything that we measured. This is actually high economic and reproductive risk, in particular poverty in this case. And so the highest brown areas are representing census tracts where 45 to 77% of families live at or below the poverty level, official poverty level. Even the orange areas are 27 to 45% of poverty level. So you can see there's quite a bit of poverty in Baltimore. We chose these areas here as target areas, so that's where these centers were built that I told you about. They did outreach to 70% of or more of the population, in the pregnant population in those areas. And so we were trying to figure out what a good comparison group would be. Does anyone want to think about, hazard to guess, what might be a good comparison group? Yes? That's actually what the national evaluation did. I have an opinion about whether the context was the same or different, or what are you really matching on? I mean, the context was very different in my opinion. But yes, that's certainly one candidate. I mean, each comparison group that you have has pros and cons. Okay, so in the interest of time, I'll go forward. I'll tell you a little bit about what we ended up doing. We picked 2 comparison groups, and I'll tell you about the data sources. The first comparison group is we chose, so one thing you should know is we chose our target area at the time of applying for the grant. And at the time that we were applying for the grant, there wasn't much thought given to the evaluation at all. And so the target areas were chosen partly through political reasons, very much through data reasons that I showed you. They were sort of equally matched, the highest risk areas. And had we been thinking about the evaluation, I think we would have designed it differently. So let me just tell you what we did specifically. When we did the needs assessment, we identified those areas that were in dark brown. This is the same map. But what it tells you is the ranking of the census tract in terms of the riskiness of the census tract. So if you look at our 2 target areas here, and here, you know, they come up with kind of the same average. They're the highest ranked, one meaning the highest risk. So they're the highest ranked census tracts in terms of risk, socio-demographic and reproductive risk in the city. And there weren't other clusters that kind of did as well in terms of coming close to the ones that we chose. And also there were other contextual factors that we had to think about in terms of main streets going through neighborhoods, et cetera, et cetera. So one group that we chose, we tried to get another census tract that was similarly high risk, but the 2 candidates were this area here and then here. But this was so close to one of the catchment areas that we thought that there might be too much contamination, so to speak. So we ended up choosing this group here. Now, the reality is that group is not as high risk as the 2 target areas here. And so all in all, when we looked even at their baseline profiles, they just weren't as high risk. So it's not an ideal group, even though they were in the kind of highest third or maybe more, highest third risk in the city. The other group that we chose is a group that was in the target area. So each target area had a center, as I mentioned, and the center actually went out every 6 weeks. They knocked on every single door in that target area, identifying women who were pregnant or had recently given birth. telling them about Healthy Start. By the way, Healthy Start had a great reputation in both those communities. As I mentioned, they offered a nice center with all kinds of services that, that maybe people didn't have at home. As I mentioned, there were free laundry services, drop-in childcare, WIC, et cetera. And they would try and enroll women who were eligible. And they definitely got well over 75% of the women to enroll in Healthy Start. Now, some women enrolled prenatally, and then some women enrolled postpartum. And you could enroll if your infant was up to 6 months of age. So we actually used as a control group the women who enrolled postpartum. In theory, we thought they were just as motivated to enroll in a program as women who enrolled prenatally, and they had many of the same sociodemographic risk factors. And so new mothers who enrolled up to 6 months postpartum were the comparison group to women who enrolled prenatally. So again, they were exposed to the same neighborhood context. They had comparable levels of eligibility for program participation, comparable levels of medical and social risk, and the motivation to participate was similar. So this is a breakdown of this second comparison group of women. They're fairly similar, and there are some differences. Women who were in the comparison group didn't get into prenatal care as early. So you can see 64% got into prenatal care in the first trimester compared to about 75% who did postpartum. Sorry, prenatally. So those were our two comparison groups. Again, neither one of them are, so I started to show you some data I'm happy to show you for this group. It did show differences. It did show that the women who were in Healthy Start had better outcomes. I'm sorry, the women who enrolled prenatally had better outcomes. And we did a bunch of other analyses. So we also adjusted for people who enrolled early in prenatal care. And we thought maybe substance users would be less affected, so we sort of adjusted for that. We did a whole bunch of analyses, and it still showed that those who enrolled prenatally were better off. But again, you still don't know if there's a little bit of that selection factor in there. Maybe they were the most motivated group living in the neighborhood. But I just wanted to share with you some of the options that we had of either identifying another geographically similar, but not really that similar group of people, or trying to play within the target area of getting a group of women who were motivated to participate, but didn't enroll prenatally, and so they didn't benefit during that pregnancy from Healthy Start as another comparison group. So any comments about selecting and I'm not saying these are the only methods, but I'm just trying to share with you how we had to be creative. Again, ideally, we would have thought about the design of the outcome evaluation before we selected our target area. If we had done that, we could have selected an equivalently high-risk target area to be a control site, but we didn't. Any thoughts or comments? Yes?
I just had a question. So the adjusted odds, how was it adjusted?
We adjusted for, what did we adjust for? We adjusted for, I think, the ways in which they were different. So whether they had a short interpregnancy interval, and I'm not sure, I think that might have been it. We might have adjusted for a few other things.
Was it a regression?
Yeah. Other comments or thoughts? So what about questions about the assignment that you have, that you're going to be working on in the next hour or so. I think that's about right. So you'll be designing an outcome evaluation there. Everything's crystal clear. Yes?
I have a general question, just kind of related to program evaluation and work. Say you're just doing a simple community survey, but you've been tasked with evaluating that. Would you focus more on process at that point? And
So your intervention is doing a community survey?
No, we're just doing a community survey, and then we're supposed to evaluate how that went. I'm thinking that's more of a process evaluation at that point.
Probably, unless, I mean, yeah, it sounds like it to me, unless you expected the community survey to have an impact, like let's say it was going to raise awareness about the nature of the problems in that community, and so your target of that community, the results of the community survey might be service providers, then you might evaluate, how did service providers take that? Did they already know that, or was it new information? Maybe I'm going beyond what your question is, but...
No, but I think you're going a little bit beyond the scope of what we intended to do, but I think it's a good idea about how other folks in the area would use that information.
So it might be more about relevance in terms of the target audience as well as your dissemination plan. Did it actually reach the people who you intended it to? But
Those are some good ideas, thank you.
okay, any questions about the assignment at this point? Of course, you can ask questions as we're going along.
You talk about data sources a little bit, about the idea of surveillance system.
Yeah, thank you. Thanks for that reminder.
Yeah,
okay,
sorry.
good. I won't be able to leave the room if I don't talk about that issue. Last year when we taught evaluation, there was the issue about, I don't want to say frustration, but the lack of routine data sources to be able to use in evaluation. So imagine that for Baltimore at that time, if we had, for example, we used a lot of vital records data. If our so the vital records now has WIC on it, right? Whether you have WIC or not, no? Yes? I saw a head shaking this way and then I heard yes. So anyway, imagine that we could have more information than just WIC. And imagine that it could be tailored to something local, where you would be able to know if women or families, however you want to frame it, are participating in certain programs. That would be a routine source of information that you would have available to you. Of course, the quality is as good as the vital records are. To be able to say, wow, we can now sort all the births in Baltimore on whether or not people participated in Healthy Start or other programs. So there were other programs that were going on. So there was a citywide nurse visiting program that the health department was running. Now it coordinated with Healthy Start so that ideally not many women got both, but that was another program that was going on at this time. If there was information routinely available in our routine data sources, it would be much easier and better to do evaluations. Now, not the perfect evaluation, but right now we've got nothing. So we can analyze vital records to death, and we don't know whether or not the people we're analyzing were in one program, two programs, what kind of programs. We don't know any of that right now. I think that really contributes to this imbalance in epidemiology in particular of just focusing on describing problems versus being able to have the resources that we need to use some of our routine data sources to really inform some evaluations. I mean, another idea for surveillance would be to use PRAMs. So PRAMs has some program participation in there. It's longer, and so you have the ability to ask maybe more detailed questions, not yes or no, did you participate in program X, but it could be, For how long? You know, were you a 2-month participant, a 6-month participant, a 7-year participant? That could be potentially another source. But does anyone know why PRAMS doesn't do more of that? I guess because the state has to buy into it, and it has to be local, and that to me seems something that could or should be done.
Typically, when they add questions to PRAMS, there are space limits in PRAMS, so PRAMS can't go over a certain size limit. And typically, if a program wants to add programmatic questions to PRAMS, they have to put in an application. They typically have to pay a fee,
I see.
at least where we are, to actually add the questions and have that added onto the data collection module. So given the space limitations and given kind of the limitations of kind of approved questions and whether there's a national standard for those questions, there are some limits on what you can put in PRAMS.
I see. I mean, I don't know, but do we really need another study looking at low birth weight and smoking, with all of these data? And I know that's my personal bias. I would much rather move some of those variables aside, even for a couple of years, and then make room for some evaluation relevant data to be able to use some of these data sources for our evaluations. Yeah.
So I also wanted to clarify, with PRAMS, because of the way we oversample, it really depends on whether you get enough people that's in the program to answer the question that you want. So we oversample in Massachusetts. We do it by race ethnicity because we want to address disparity. So that might some of these women we oversample might still not be in the program you're looking for.
But we can then get a prevalence, couldn't we? Like
you can get prevalence. Yeah.
There we can start to begin to get at reach. Are we reaching our populations? I think right now we don't have population ways of kind of doing that. Anyway, these are my opinions. What are your ideas, and what do you think are possible in your areas to try and introduce some evaluation-related data into some of our routinely collected data sources? Is that something that has been discussed in your areas?
So in Los Angeles County, we do have our own version of the PRAM, and we call it LAM, Los Angeles Mommy and Baby Survey. And we routinely add questions. It's a every 2-year surveillance. And so we do add questions from our program people on things that they would like to track that are used in evaluation programs.
Is it program participation? Oh, great. Maybe you could make that available. Or is it online so that we could look at it if we wanted to? Yeah, great.
I think with PRAMS too, it just requires a little planning in advance too. I feel like you're probably a little more flexible, and it happens more quickly. I know with the PRAMS process, adding questions takes a while, but then when you're getting your program up and running, or when you're planning it, that argues for thinking more about the evaluation at that point in time and thinking about planning these measures in for later. And the nice thing about PRAMS is it is annual, so if you do need to kind of group years of data, if you don't have enough, program participants in 1 year, for an analysis, that might be a possibility, even though you lose a little bit of the secular the trends then, right?
I mean, to be honest, I think these ideas aren't really even raised very often. We tend to think of evaluation as after the fact. Oops, I did this program, how can I evaluate it? And then you scramble to try and find information rather than being proactive or thinking about the outcome evaluation design as we're designing our program. So I kind of understand how that falls through the cracks. But I think I would love to see more intentional design of our routine data collection data sets to begin to think about it. Let's even pilot it. Let's see how that goes. Deb.
Just another example, I guess. I know in Illinois, can you hear me? Yeah. In Illinois, and Ashley and I were talking about also sample size issues, but the other example here is CSHCN. So like on NSCH, even there's the screener, but thinking that, what is it, 30% of Title V dollars goes to CSHCN? We can't tell from the national from our state, the Illinois version of NSCH, who's in the program. So like, we've spent resources too doing a separate survey, like for the needs assessment, separate work for the CSHCN program, and wouldn't it be nice if that was part of the national data collection process, receiving Title V dollars. And maybe it's a question, you know, of when we think about the complex sampling strategies, maybe we have to oversample for people in the programs that are requested.
Yeah.
So,
Great. So write this on your evaluation forms that you're doing so that the Bureau gets that feedback that we need to start having more of a focus on our routine data collection or our national surveys on program participation.
I would just say, because I do know about the surveys, at least my office runs them, that you can't really oversample for CSH scan. You have to do a screener. So there's like no way to do that. You don't know from the outset what household has a CSH scan.
But isn't that the purpose of screeners? So then you're like, okay, no thank you. You like weight participation by people who participate? Because screeners about eligibility, isn't it?
you could ask about if they're important to, when you identify.
Yeah.
Then the other thing is being able to accurately report that you're in a program. I don't know if a participant would know that they were in a Title V funded program.
So you have to have names of programs. You have probes, just like we do for other
Right.
questions.
But that's been the problem for home visiting too. There's so many home visiting programs that when you just ask if you're in a home visiting, you know, received home visiting services, you're not sure if you're in the MCHB program or Healthy Start or
So I think they're less than perfect for sure, but even knowing that somebody is in a home visiting program, I think is better than knowing nothing at all. Ideally, we would know they're in X home visiting program, but we know that there's error there. I think there's an opportunity for us to collect more information about what kinds of programs people are in so that we can even get a sense about, we're spending all these dollars, you know, how many people do we actually potentially reach?
Mm-hmm. Yeah, I think we can definitely incorporate that for family-to-family health information centers. But yeah, that's a real challenge with the CSHCN because I don't know that we would do a screener and then stop the survey to try to oversample because you don't know that from the outset.
But you could at least ask, but even if you're not going to oversample, you could at least like.
Okay, let's think harder about this over lunch and stuff. I'm sorry, I just want to keep us going.
Yeah, good. Okay, so I think our time's up, right?
Yeah, so let me just explain the logistics. So you have this half hour now just to start thinking about your outcome evaluation. And now just to clarify, you're doing the outcome evaluation for the Healthy Start program as a whole. So you guys were doing process evaluation for components of the program. So now you have the logic model for the entire program and thinking about whether Healthy Start is having the impact as a program, all of those different program activities, Healthy Start in housing plus the CAN plus all the other things listed in the logic model. Is it having an impact on community level outcomes? And so you have just a half hour to get started thinking about it now. Then we're going to have the propensity score lecture starts at 3:30, I believe, in this room. If you want to attend that, or the Q&A is in the other room. If you want, Ashley and Deb and Pat will be in the other room to answer any kind of questions you have about your own work or that. But the idea, the outcome evaluation exercise will be finished tomorrow after we have this propensity score lecture, and then tomorrow morning we'll have a lecture on trend. And the reason that you finish up tomorrow is so that you can think about maybe those are strategies you want to incorporate into your outcome evaluation, maybe not, but we thought we'd give you that opportunity. So just get started now. You'll have more time in a group tomorrow before you present.